All right. Good morning, folks, and welcome to Friday Chalk Talk. Today, I have the pleasure of introducing a returning guest, Dr. Leanne Groban. Leanne is currently one of our fabulous palliative medicine fellows here at Advocate Aurora in Milwaukee. And her topic is going to focus on her career-long passion of heart failure by leading us through a really challenging hospice case of refractory depression in end-stage heart failure and how ketamine played a role in that treatment. Our format for today is going to be two parts. It's going to be primarily a presentation, probably closer to 30 minutes. We really have a packed topic today, but we'll have just a minute or two at the end for any questions. And so with that, thank you for being here with us today, Leanne, and I will hand the mic over to you.
Very good. Thanks a lot for the opportunity. I do have to disclose something. This was a case that happened before I started my fellowship, but I really thought that it was really interesting as I started using ketamine in the hospice arena as well as the palliative care arena. Dr. Sharma shared this case with me. And again, because it had heart failure and ketamine, and I'm an anesthesiologist, I thought there are a lot of really important points. I went through the chart, and so I'm pretty familiar with all that happened. So before I really get into it, I want to just give you a little background, or just why do we even treat psychological distress in patients with terminal illness such as heart failure? And just so you know that patients with heart failure, the prevalence of depression is about 50%. And we know that just having depression can really increase mortality in these patients with heart failure. But really, just in general, why do we treat depression? Well, we know it impairs patients' capacity for pleasure, meaning, and connection. It erodes the quality of life, amplifies pain and other symptoms, and it reduces patients' ability to do emotional work like saying goodbye. And then it causes a lot of anguish and worry in family members and friends. So it really behooves us to recognize this and really get on top of it and treat it. So today's session, we're going to break it up into 3 parts, and it is packed, but I think it's going to be a nice review. We're going to go ahead and distinguish between major depression and preparatory grief. I wanted to learn the antidepressants, so I'm going to review what I learned and categorizing them for patients with serious illness, and really kind of touch upon the pros and cons in the context of heart failure. And then we'll delve into the role or roles of ketamine and the underlying mechanisms for use in the treatment-resistant depression at the end of life. So our case is this 86-year-old male with end-stage heart disease, and it was HFpEF. He had 2 cardioembolic episodes resulting in dysphagia, and this is what prompted him to get into the home hospice. And soon after initiating the hospice benefit, it was noted that he had progressive worsening of his pre-existing depression. His mood was depressed, his energy low, concentration poor. He endorsed having problems sleeping, difficulties concentrating during conversations, having a poor appetite, and increased fatigue. He also reported feelings of anguish and annoyance and agitation toward his stepsons, who were just not respectful to his wife, who was their mother. He had a history of depression. He did not have any previous hospitalizations for depression or any ECT. He was on escitalopram 20 milligrams, and just going through his chart, we found that he had ineffective trials of citalopram, bupropion, and venlafaxine. So just psychomotor, emotional, and cognitive features such as anhedonia, apathy, sadness, feelings of worthlessness, anorexia, and sleep disturbance, they often overlap at the end of life, really making it quite difficult to distinguish among such conditions as depression, preparatory grief, and even delirium or hypoactive delirium. And it's really important to do a detailed history of the onset and time of the course of the mood changes. Even looking at cognitive symptoms is important. So just in the interest of time, we'll go ahead and just briefly compare depression and preparatory grief. So really in preparatory grief, the sadness, you're going to see it's waxes and wanes where it's quite consistent with depression. Sadness about death with preparatory grief is present, but then, we're going to see the suicidal ideation or this active desire for death, those with major depression. Anxieties are present both in preparatory grief and depression. And I think one of the other things to think about, patients with grief, they're still able to have some pleasure and enjoy some of their favorite activities, whereas in depression, it's just this consistent anhedonia and hopelessness. And then our patients with grief, they still are involved with their family, whereas in depression, you're going to see this social withdrawal. So I do think it's important that we review the DSM-5 criteria for major depression. One needs to have depressed mood or irritable mood most of the day or nearly every day, or a marked diminished interest or pleasure. And then we're going to have about 4 of the things that are listed in black. I don't need to read all of them. And these need to be going on for at least 2 weeks. I've starred number 7 and number 9, feelings of worthlessness or excessive or inappropriate guilt, and recurrent thoughts of death or suicide, because I think this is really key for our arena, the HPM arena. Now, as far as symptoms of depression, if you're into mnemonics, there's this mnemonic called SIGI caps. You might remember that from medical school. I won't go through that whole list, but if we go to the right, we can kind of see that our patient definitely had depression, depressed, energy low, concentration poor, the sleeping difficulties, having problems concentrating, and then this feelings of anguish and annoyance and agitation. So again, psychomotor retardation and agitation. And that was really what was most alarming to him and his family. So going back to our case, so he came to us and he was on escitalopram or Lexapro 20 milligrams, and we continued that. We were worried about a sleep problem, so we trialed melatonin, trazodone, and risperidone, and they just seemed to be not so effective. We did make a dent with using mirtazapine 15 milligrams and lorazepam. It did help his insomnia, his anorexia, and his anxiety. And then over several weeks, he started complaining of back pain, and he had back pain with a little bit of a neuropathy. And so we went ahead and started duloxetine 30 milligrams for its neuropathic effects and its analgesic effects. And it also has antidepressant effects. We'll talk about that. And then we went ahead and started tapering the escitalopram, a slow taper to discontinue. So remember, anybody that has pain, that has depression, I mean, it's going to add to that depression. So it's really important for us to treat pain. So now we'll kind of focus on the antidepressants that are used for patients with serious illness that have these, depression. We'll talk about the pros and cons. And the exact chemical basis for depression is really poorly understood, but it's really thought that it's linked to decreased levels of the monoamine neurotransmitters, serotonin, dopamine, and norepinephrine. And you can kind of see this little picture here. In depression, we don't have many of these neurotransmitters in the synaptic cleft. And then a lot of these drugs inhibit the reuptake of the neurotransmitters, showing that we're going to try to maintain that. So let's go ahead and look at these classes. So there are 5 classes of antidepressants. The tricyclic antidepressants, while they can be useful for appetite, neuropathic pain, and for sleep, they all have anticholinergic effects. We kind of really stay away from those patients with cardiac disease. And then the MAOI agents are also contraindicated in cardiac patients, as well as those patients that might be taking St. John's wort or any other antidepressants or amphetamines. We know that it can lead to a hypertensive crisis. So our patient was on escitalopram. I mentioned he took duloxetine and mirtazapine. So we'll focus on these 3 classes in particular. So our selective serotonin reuptake inhibitors are generally the first line therapy for antidepressant. That is if the patient has a life expectancy greater than 8 weeks. Now, again, if, these are kind of hard to remember. So I did find this little mnemonic, and it's down here. If you like that, Sir Parr flew over the city to escape. So sertraline, paroxetine, fluoxetine, citalopram, and escitalopram. And actually studies show equivalent efficacy of all these, among all the SSRIs. So really the initial choice is made by patient factors as well as looking at the nuances of the drug. So for instance, paroxetine, maybe that would be something you would consider that you might have a very lethargic, depressed patient. You can use this. It's a little bit more stimulating. I would suggest giving this in the morning. And then if you have an agitated patient with depression, maybe you want to give a more sedating agent like fluoxetine, and that you would want to dose more in the evening. Now, all of the SSRIs can prolong the QT, the corrected QT interval that can lead to torsades. I think the one that is really stands out is citalopram. You're going to see a dose-dependent increase in QTC, particularly after that higher level of 40 milligrams. So that's something to consider. Again, paroxetine, it does have anticholinergic effects, so that might not be the best drug for a patient that's got cardiac disease. And then most of the studies in cardiac patients with depression, they started using, most of the studies are using Zoloft or sertraline, but now I'm finding that many of our cardiac patients with heart failure are on escitalopram, so not a whole lot of side effects. They're very forgiving drugs. Then we have the serotonin norepinephrine reuptake inhibitors. So in addition to serotonin, the reuptake of norepinephrine in the synaptic cleft can result in increased transmission. These can increase levels of both norepinephrine and serotonin, which can accelerate cardiac sympathetic activity. So you do need to think about increasing levels of the heart rate and the blood pressure, and they advise maybe monitoring blood pressure. Now, our patient was started on duloxetine. Again, we want to treat pain in patients with depression. So the good thing about duloxetine, it is good for neuropathic pain, and he did have that back pain with the radiculopathy, and he did have the depression. Just to remember, at high dosing, it can cause orthostasis, and then we do want to dose it for kidney disease. One little nuance that I learned about duloxetine is that there's a 10-fold higher selectivity for serotonin reuptake compared to norepinephrine. So that's kind of cool. And then the reuptake is a sequential. So first it would be serotonin reuptake and then norepinephrine. And then we have venlafaxine or Effexor, and that also is very good. I think there's been epidemiologic studies showing that venlafaxine may cause a slight increase in blood pressure. I think the biggest thing for us to realize is that if a patient is on venlafaxine and they're entering hospice, or keeping in the back of the mind if they're in palliative, that if there comes a time that they cannot take anything oral and we have to switch to IV, this has a very short half-life, and so the withdrawal syndrome is very common, and it's kind of nasty. So keeping that in the back of the mind, this one definitely we need to have a long taper. The atypical antidepressants, they're a group that have different mechanisms of action, and they really don't belong to any single class. I think the one thing that's nice about these medications, they can be used, they're effective singly, or they can be used to augment the effectiveness of SSRIs and SNRIs. So this is mirtazapine and trazodone. They're kind of sedating, so they can improve sleep if somebody has a sleep disturbance. Low dose mirtazapine, we know we use this for patients that we need to help with, as an appetite stimulant. The one thing about trazodone, I think that to think about this with our elderly patients, it can contribute to orthostasis. It can contribute to prolonging of the QT interval. And then the famous priapism, which I've never seen, just heard about it in medical school. And then we have bupropion, which is nice for maybe our patient that is kind of lethargic and depressed. If we want to add this to one of the SSRIs, it may decrease fatigue. Also, it can limit some of the sexual disturbances from the SSRI. So oftentimes they'll add bupropion with an SSRI. One thing to think about with bupropion, it does lower the seizure threshold. So you want to kind of think twice about this, and maybe somebody that has brain mets. Also, anybody that might be taking a medication that also lowers the seizure threshold, like theophylline or something like that. What about some other pharmacologic agents? Well, the psychostimulants, methylphenidate, 5 milligrams twice a day, that is used, and that actually is used to jumpstart these SSRIs, particularly in our patients, that are towards the end of life, or maybe have at least, maybe a month or two, and you started an SSRI. It can be used to increase appetite. So you should see a response within 2 days. And if not a response after a week, I would just discontinue it. It's just not working. Possible adverse side effects, again, tachycardia. I wouldn't have used it for our patient, mainly because he was already agitated, and I don't want to promote that agitation, and he already had insomnia. And then there's this, comment that it can contribute to cardiac decompensation, but most of our patients that are coming on palliative or even early on with heart failure and they're getting into hospice, many of them are still taking their beta blockers and their medications. So I don't think that that's a big concern. And then we think about low dose atypical antipsychotics for depression like quetiapine, but we don't have time to talk about that. So to move on with this case, there's definitely, he had depression. It was really felt that his distress was focused on real issues relating to the illness. He was really concerned about the burden of care that he was putting on his wife and his daughter. He just continued to have this mistrust about his stepsons, and he just felt like he was losing control. We talked to him about this. We offered a trial infusion of low-dose ketamine in our inpatient hospice facility. He was in agreement of that. We wanted to get a psychiatric evaluation before that, just because of his suicidal ideation. And so we went ahead and did that. And I'm not going to spend time on the exam, but just to remember, somebody that does have suicidal ideation, we want to look at attempts. Do they have a means, a plan? And he denied that he ever had attempts. He admitted to having means. He said he could shoot himself, cut himself. He's got blades, but he said he was way too chicken to do anything. And there was no family history. So we're going to switch gears now to the meat of the matter and talk about low dose IV ketamine for treatment-resistant depression at the end of life. And because I'm an anesthesiologist, I feel like I need to give you a little bit of background. Again, we're talking about intravenous ketamine. This is racemic ketamine. It's actually ketamine hydrochloride. And in my arena, it was approved in 1970, and we do use it. We use it as an induction agent, giving, and that means that's when somebody's lined up, they have the mask on, all the monitors on, and we go ahead and induce anesthesia, and we give 1 to 1.5 milligrams per kilo. And it's over one-fold. It's quite higher than what we do for depression. And we see this dose-dependent cataleptic, amnestic, dissociative and analgesic effects. The cataleptic state is an akinetic state with the loss of orthostatic reflexes, but there's really no impairment of consciousness. And then the dissociative state is kind of unique in that the patient appears awake, but they're very detached from their surroundings and their eyes remain open. So it's kind of a bizarre way to induce anesthesia. It also can cause a lot of salivary secretion. So if we're going to use a high dose, we would give glycopyrrolate to try to limit the secretions. So where do we use this? Well, we would use it if somebody was coming emergently to the OR from a trauma, hemorrhagic, or septic shock from the ICU, someone with hemodynamic instability, because it does maintain hemodynamics. We would electively use it for a patient that has reactive airway disease because it does dilate the bronchioles. Other places we can use intravenous ketamine in the burn unit for dressing changes. We use it for short-term sedation. And then we might add it to propofol. We call it ketathol for a patient that might be having a hip replacement, a knee replacement under a regional anesthetic. And then we want to keep them kind of sedated during that case. Again, it maintains oropharyngeal and laryngeal reflexes. So that's kind of why we like it. Now, the antidepressant effects or antidepressant uses, again, IV ketamine is off-label for antidepressant use. We'll give 0.5 milligrams per kilo over about 40 minutes. There are some side effects. They're short-lived: nausea, headache, dizziness, maybe very transient changes in vital signs, and very mild dissociative effects. The antidepressant effects are rapid, and we'll review a case or two, and they're long-lasting. And about 70 to 80% response rate in those patients that failed multiple medical trials or even ECT. So this is on the left is a study by Zarat et al. This was in Archives of General Psychiatry in 2006. This was a placebo-controlled double-blind crossover trial in 18 patients with treatment-resistant depression. They received 0.5 milligrams per kilo of ketamine over 40 minutes versus placebo. And they used this Hamilton Depression Rating Score for depression. They've actually found 71% met the response rate at 24 hours. So really, you can see that, the depression score was down, and this was maintained by 35% maintained this scoring over the week. On the right is actually another use for ketamine for those with suicidal ideation. This is a study done by Ballard, and actually, and it's looking at single dose IV ketamine. And this was 4 independent clinical trials in patients with treatment-resistant depression. It was 133 patients. And they compared ketamine to placebo, and they found significant reductions in suicidal ideation compared to placebo. And these improvements in suicidal ideation after ketamine, well, they might have been related, but they were not driven by improvements in depression and anxiety, suggesting that maybe this the ketamine effects on suicide may be through a different mechanism than just depression alone. So how does this work? So we'll go on to this left side to just see how simplistically it works. It basically blocks the NMDA receptors that are on these inhibitory neurons. And really by blocking them, it leads to an increase in activation. Basically, ketamine stops the inhibitory neurons from putting the brakes on. And so that we get this big increase in glutamate, and then glutamate's going to bind to the AMPA receptor. So if we go over here to pick this apart a little bit further, ketamine binds to the NMDA receptor, blocks it. We have this barrage of glutamate. Glutamate is going to activate these voltage-gated calcium channels, which is then going to activate the release of brain-derived neurotrophic factor. And BDNF induces translation and synthesis of synaptic proteins for synaptogenesis, and this is via the mTOR signaling pathway. So animal studies have shown that ketamine reverses the deficits in synapse number and behavior in animals that are exposed to chronic stress. And thus, it's really thought that ketamine results in a functional reconnection of neurons that might be involved in depression. So there's a lot of work in this area, and this paper by Carboni is actually from 2021. So what about the relative contraindications? And I put a question mark under subanesthetic use because the relative contraindications are primarily based on its use in the anesthesia arena, where we use very high doses, and maybe some in the pain arena. So although we've used ketamine for depression in many studies, the studies are very small. And then remembering that in these studies, these patients aren't at the end of life. So they don't really have a lot of comorbidities. Maybe they just have depression. So we just really need to extrapolate. So the big key things contraindicated would be, I would say, cardiac decompensation and severe liver dysfunction. And we'll talk a little bit of what do I mean by that. But again, I probably would not go to ketamine if somebody was in active psychosis. In our literature and potentially for depression, I wouldn't use it for somebody that has increased intracranial or interocular pressure, because it can slightly increase blood pressure, just enough that if somebody does have brain swelling, so somebody with brain mets, I wouldn't choose that. Somebody that maybe has had a recent stroke, maybe not somebody with glaucoma. Poorly controlled cardiovascular disease. So what do I mean by that? Let's say somebody's blood pressures are 160, 170. Maybe I would not go using IV ketamine for depression. Somebody with a heart rate of 120, no, I probably wouldn't use it. But otherwise, yeah, I think most of our patients are pretty well controlled. Hepatic dysfunction, I'm talking like a 3-fold higher bilirubin from normal. No, I wouldn't use ketamine. And then if somebody's had a previous adverse response to ketamine, I wouldn't go to that. So I thought that this study was kind of interesting because we're talking about a cardiac patient, and we know ketamine can maybe increase blood pressure and heart rate. So this was a study that involved 35 patients with major depression, and then they added 15 patients that had hypertension, no depression. And they went ahead and they dosed the ketamine, the 0.5 milligrams per kilo over 40 minutes, and they monitored heart rate, blood pressure every 15 minutes. And so what we're seeing here, and I just want everybody to see that, what the y-axis is, because it's pretty incremental, even though we're seeing a significant, increase in blood pressure. This was significant, but here we're saying, and this is occurring within 30 minutes of the infusion, or the infusion's 40 minutes. So within 30 minutes, we might see a blip in the systolic blood pressure from 130 to 138. Okay, if somebody has high ICP, that could be significant, but really, is that really clinically significant? And really also just to know that after the infusion, within 90 minutes, patients return to their baseline or even slightly below. So I think that it's relatively safe, and we were not concerned about our patient that had heart failure. So just about modes of administration of ketamine, we talked mainly about what's in the literature, the 0.5 milligrams per kilo over 40 minutes. If this does work, how often should we be doing this if we've got some time? So I would say Q3 days over 6 infusions, so maybe 2 weeks. And then, considering a maintenance every 3 weeks, or if a patient has a relapse, we would want to consider. Now, I think it's worth talking about intranasal S-ketamine. So all of these other things we're talking about is racemic. So S-ketamine is Spravato. That is FDA approved for treatment-resistant depression and for suicidality. The dose is 10 to 50 milligrams. And that's given anywhere between every 3 to 7 days. This is delivered. Some psychiatrists are licensed to do this, or they have the place to do it, because these patients come in and they need to be monitored for 2 hours. Their vital signs need to be monitored. So they'll take the intranasal ketamine, and they have to just sit around for 2 hours. There are some studies of oral ketamine, 10 to 100 milligrams every day to 3 times a day. Again, this isn't going to work as rapidly as the intravenous, but there are data to show that this might be effective. And then subcutaneous, and I just brought this up because this is a paper in BMJ, and it's actually just talking about a feasibility study, subcutaneous ketamine infusion in palliative care patients with advanced life-limiting illnesses for major depressive disorder. So this was given subcutaneously, starting at 0.1 milligram per kilo over 2 hours. And then every week, there they're planning to ramp it up 0.1 milligrams up to 0.4 milligrams. So this is something that we can consider, maybe for our patients that are going to be around for a little bit longer they don't have IV access. So let's go back to our case. We did admit the patient to Zilber Hospice under GIP care. He did receive the IV ketamine. We were monitoring his blood pressure using an automated blood pressure cuff every 15 to 20 minutes. There was no overt change in his blood pressure or his heart rate. We did have continuous plethysmography, pulse ox on his finger. He did not have any nausea, headache, or hallucinations. Within 24 hours, his deep-rooted exasperation toward his extended family just really seemed to subside. And that was our biggest issue. We wanted to try to just level things out with him. He was discharged home after 4 days. So he did come in over a weekend. He had an improved appetite. His sleep disturbance was reduced, and he had improved engagement with his family. He was considered euthymic for about 2 weeks before he died peacefully at home. So for him, it worked. And maybe this is just an N01, I don't know. But just to go back for some of the takeaways, psychomotor, emotional, and cognitive features of grief and major depression, they often overlap, muddling the diagnosis. You should keep these in your differential, really need to do a detailed history of the onset and time course of mood that helps to figure out what's going on so that we can treat it. SSRIs are our first-line antidepressant for heart failure patients if they have a life expectancy greater than 2 months or 8 weeks. How do we choose them? Well, they're equal efficacies for all of them. So your initial choice is really based on patient factors and drug nuances. And then the atypical antidepressants, if the SSRIs aren't quite effective, you may add one of these drugs used to augment the SSRIs or the SNRIs. And then finally, treatment-resistant depression is a critical problem among some hospice patients. It really contributes to total body suffering. The rapid effects of IV ketamine may be an effective treatment for terminal patients with suicidal ideation and depressive symptoms. And then I've got a list of references, but thank you so much for listening. And I hope that I just could remind you of some of these interesting facts about depression at the end of life. And I can open it up for questions.
Thanks, Leanne. That was fabulous. I know we're at time, so if people need to leave, that's fine. Otherwise, we'll try to stick around and answer as many of these as we can.
Otherwise, happy Easter, happy Passover, happy Ramadan, whatever. Everybody have a good weekend.
Thanks, Leanne. Appreciate your time.
Okay. Bye.
Bye.